There were two presentations from the Elranatamab program. Elranatamab is a BCMA-directed CD3 bispecific T-cell engager. There was a first-in-human phase 1 study presented by my colleague Nupur Raji earlier this afternoon. This study included 55 patients that were treated at doses above the effective dose range. And the data presented essentially demonstrated that among these patients, 64% had an objective response rate, and that responses were quite durable and with excellent duration of response and PFS. The second abstract was the presentation from MagnetisMM-3 study. This was a non-randomized two-cohort phase 2 study for patients with triple exposed multiple myeloma. There were two cohorts, a BCMA naive cohort and a BCMA exposed cohort. The 123 patients enrolled on the BCMA naive cohort were the patients that were whose data was presented. Among these patients, the objective overall response rate was 61%, and median duration of response was not reached with a median follow-up of approximately 10 months, if I'm recalling correctly. For both of these studies, the main toxicity, or the most frequent toxicity, was, of course, CRS. Events were generally grade 1 and 2 and were very predictable in their incidence, occurring largely with the first, second, and occasionally with the third or target dose. In the MagnetisMM-3 study, the phase 2 study, the step-up dosing and pre-medication had been in its most sort of optimal stage for the program, and in using these mitigation strategies, the overall incidence of CRS was around 56%. Again, no grade 3 events. ICANS occurred rarely. I think there were, if I'm recalling correctly, 4 cases of the 103. Most of these occurred within 2 days, both the CRS or ICANS, and had a median duration of 2 days, and could readily be managed with either tocilizumab or a steroid. Infections are a major non-hematologic toxicity related to, I think, many bispecific therapies, and especially the BCMA-directed bispecific therapies, and that was certainly observed in both the MagnetisMM-1 and 3 studies at sufficiently high incidences to be of concern. There are emerging recommendations to monitor for hypogammaglobulinemia and use IVIG replacement therapy, to incorporate PJP prophylaxis with Bactrim or equivalent, and to give zoster prophylaxis with acyclovir or valacyclovir, as well as to monitor for other emergent reactivations or infections with viruses such as CMV, hepatitis, EBV, and so on.